Did you know your belly button gets a whole new address during a tummy tuck? Where does it go? Is it even still your own belly button? Today on the Doc Dudes, we're uncovering the truth about tummy tucks, belly buttons, and much more. Stick around, you won't want to miss this.
Welcome to the Doc Dudes, your premier podcast for a behind-the-scenes look at the latest in aesthetic medicine. Hosted by the cosmetic surgeons at Graper Harper Cosmetic Surgery in Charlotte, North Carolina, the Doc Dudes brings you interviews with insightful guests, expert tips from experienced medical professionals, and lots of laughs along the way. And now, here's Dr. Garrett Harper and Dr. Evan Zug, also known as the Doc Dudes.
Welcome to another episode of the Doc Dudes. I am Dr. Garrett Harper here today with
Dr. Evan Zug.
We are both board certified plastic surgeons. Our partner, Dr. Robert Graper, is not with us today, so we apologize, but I'm assuming it'll be much more PG-13 without him here. Probably. Yeah, probably. We'll see, but I hope he's doing well and enjoying yet another vacation. But today on the Doc Dudes, we're tackling a hot topic. I mean, we get asked all the time about tummy tucks and belly buttons. I mean, I've never had so many people in my life talk to me about their belly button than when I became a plastic surgeon. I just didn't know that it was, I don't know, as big of a topic as it's become, right? So we're going to look at that. We're going to look at some other key facts and set the record straight on stuff. Before we get to that, Evan, I mean, what's a tummy tuck? Like when somebody says, like define mini and define, and I mean mini, like M-I-N-I, not M-A-N-Y, mini tummy tuck. And what's the difference like in the incisions? What are some kind of philosophies that you have? And then I'll share mine. They're probably pretty similar because we operate right next to each other all the time. So, but let's talk a little bit about tummy tucks. Like define a tummy tuck for a patient.
Yeah, so I would say most patients really typically need a traditional abdominoplasty or tummy tuck, but sometimes if they just have a little bit of extra skin, we can limit the length of that incision with a mini tummy tuck. Right. If they just have a little bit of extra skin or fat, then what we call a dermalipectomy, where we just remove the skin and fat and not have to plicate the muscles, put the muscles back together. Right. That's common in weight loss patients.
So like a common way that I kind of tell people to think about it is, derma means skin, lipo means fat, ectomy gets like, get out of here, removing it. So a dermalipectomy is a removal of skin and fat, which we're going to do with a tummy tuck or its namesake, a dermalipectomy. But a tummy tuck means I got to do something to your muscles, So talk about what we do to their muscles. When somebody says, oh man, is this going to be like my C-section? Like, I mean, it's not an incision, it's a repair. So we're not cutting any muscle and it's in a complete different, vector. I mean, it's a total different kind of scenario. So what are you doing when somebody says, are you going to fix my muscles?
Yeah, so we use the term plication, but whenever you have a widened muscles or diastasis recti is what it's called after having babies, your six-pack muscles, are the distance between them has increased and your abdominal cavity has kind of lost that contour. Yeah. So we're putting that back together where it used to be. Yeah,
because it kind of allows you to be more round than you'd like, right? Mm-hmm. And so what I tell people is, I think probably the only thing I remember from embryology is, we start out as like our spinal cord. It's actually called a notochord at that point. And so just imagine like it's a long toilet paper roll. And that's our spinal column. And then all these nerves, right, start generating. And so they start from your back, and then everything kind of wraps around to the front. And the last part of our body to be formed is our front midline, like right in the middle. And that's why you can have so many deformities there, right? Mm-hmm. Cleft palates, cleft lips. And this diastasis, what I tell people is, it's your stomach muscles, your six-pack muscles, that go from the bottom of your ribs down to your pubic bone. That's their origin and their insertion. And that doesn't change during pregnancy. Mm-hmm. But what does is whether or not they're being held together, close together in the midline, right? And so that midline is also where our belly button is, right? Or the umbilicus, when we talk about umbilical cords and things like that for little embryos and babies. So the belly button also can kind of spread apart. And that's why a lot of pregnant bellies have this kind of crazy, it looks like something's trying to grow out the belly button, because that belly button hernia, that separation gets even bigger with that diastasis. So sometimes we got to kind of fix both of those things, right? The belly button hernia and that. And so so if somebody says, look, I'm 30 years old. I've got 3 kids. We love them. I think we're done having kids. I'm not sure. Trying to talk my husband into another one, but I just don't like the way my belly looks. How do you handle that? I may handle it differently, so I'm not trying to put you on the spot, but how do you handle that? What do you say to that patient?
As much as I love to operate, I want them to be done having babies.
Yeah.
Because I know that result is not going to, there's a chance that you may not have that great result after having another baby.
Sure.
You may have those muscles stretch out again.
Sure. And so, what I tell people sometimes is, when I take somebody who knows they're done, right? I tell somebody, I'm going to put your muscles back together with both absorbable and non-absorbable suture. And not everybody does this. I remember we used to only use non-absorbable. And we would use this huge looped nylon with a harpoon on the end of it. And I mean, the knot that you tied for it, you could feel through your skin.
Yeah.
I mean, it was crazy. So now we use barbed suture that stays in there for 3 to 6 months, which is, the time period where the vast majority of the strength of your repair is going to be healed. But I do use a soft stitch every inch or so along their diastasis, and I do a figure of 8 stitch with a stitch called an ethibond. And it's probably unnecessary. It's just kind of a belt and suspenders. But I know that if somebody comes back and they say, oh, I think my diastasis is separated again, I'm like, there's no way. Because I know I've got those sutures in there. But other areas of their abdomen, right, like their obliques and where their obliques insert onto their 6-pack muscles, that can separate a little. And that can make it to where you don't have the ideal flat abdomen that you want. I also want, because I just said it incorrectly, I also want to dispel a misnomer about when somebody talks to you about having a flat stomach. Are stomachs flat?
No.
No, right? I mean, I think when people, and I know the tall tale sign of some patients when I see them post tummy tuck from other places, things are pulled so tight. It has zero contour. Like even our fat distribution to our abdomen is different, and there are areas that just hold more fat than others. I mean, there tends to be a little donut of fat around your belly button, and that fat's kind of there and kept things warm, I guess, when you were in utero or something like that. But it's just interesting how people want this flat abdomen that looks very unnatural and is one of the, quine sine non of like having a tummy tuck.
Yep.
Most of my patients want to have surgery and don't want people to know that they had surgery. They want people to think they probably had it because it's impossible for someone to have that great a figure after they've had 3 or 4 kids. But they don't want just that alien kind of look where it looks like your skin's been tucked in.
Yeah,
or anything
know exactly
like that,
what you're
right?
talking about. And when I think of the abdomen, I'm thinking of the whole trunk.
Right.
Right.
Right, which is, and I say sometimes, like, do you add liposuction to your tummy tucks, and where are the most common areas for you to liposuction?
Yeah, you have to be thoughtful about doing liposuction because it can affect the blood supply to your flap.
Yep.
I typically will do liposuction of the flanks a lot of the times when I'm doing a tummy tuck, and the blood vessels that supply the most distal aspect of the abdominoplasty flap are in the superficial fat layer. So that deep fat layer, then when we lift that flap up, is almost parasitic fat.
Yeah.
So I'm conservative, but I do, if they do have a little bit fullness in the upper abdomen in that deep layer of fat, I will liposuction that some as well.
And that's good from an anatomical standpoint for patients to know, I feel like we said it in a podcast before, we're all made up of superficial and deep fat compartments. And then there's like a really nice connective tissue layer that separates those two. And so you're right, the meat and potatoes for the blood supply are in that superficial, meaning right underneath the skin. So we don't go buggering up that area too much, but you can do a lot to that deeper layer to help with kind of contours. And in some of those patients, you're actually doing removal of some of those fats, sometimes in strips, sometimes with liposuction.
And ideally, I like to get them to lose the weight on their own before.
100%.
It's going to have a much better result than having to do that.
100%. And I tell people, I'd love for you to be within 10 pounds of a not ideal weight, because I think sometimes people have a really hard time being honest with themselves about what is ideal, or maybe they don't understand that their body's changed after pregnancy. And so when you used to, hit the scales at 125 pounds in high school, and then you had 3 kids and you're running around all day and your hips have changed and your body's changed, and, you're 140 pounds now, 145 pounds, and you say, well, I want to be back to my 125, that, you'd be unhealthy to do that. The body definitely changes after pregnancy. But I say, I'd love for you to be close to what weight you think is perfect for you, fighting weight, and that you're not just kind of killing yourself to get there, right? Like split pea soup diets are not good. Right. I don't want you only doing that for, 2 months so you can lose that last 20 pounds. And I'll say, you probably have seen it too. A lot of patients have had a lot more success coming to us at that kind of fighting weight, that best weight, with the use of GLP-1s.
Oh, yeah.
I mean, that's really changed things.
It's changed the game.
Yeah. I mean, I used to have patients that maybe, 30 pounds, 40 pounds over what their fighting weight would be. And I would tell them, you could do surgery today and you could get a good result, but I don't want you to get a good result. I want you to get an awesome result. So let's lose this 30 pounds. And I'd tell them, there's all sorts of books at Barnes & Noble. And I'd say, there's Barnes & Noble right up the street. Like, go up there and go to the diet section. And, if you need to get on paleo diet or start taking factor meals or whatever they want. And I would never see those patients again.
And the chance of them coming back is slim to none.
Well, they don't. They're just going to go straight.
It's hard.
Well, and they'll go right down the street. Yeah. And another doctor will say, don't worry about it, we'll liposuction that, which is crazy. Yeah. Because the most liposuction you could ever do on somebody is like 10 pounds.
Yeah.
By the time you add it all.
Loss.
That's exactly right.
It's hard for patients to understand that.
Yep, absolutely. Okay, so a tummy tuck is a removal of skin and fat and repairing the muscles, bringing the muscles back together. A dermalipectomy is when you don't do anything to the muscles. A mini dermalipectomy or a mini tummy tuck means you are going to rejuvenate and take care of the skin from the belly button to their pubic bone.
Yep.
But we don't go north. We don't go higher than the belly button. So if you've got loose skin between your belly button and your breastplate, that ain't getting helped. Now, there are some ways that you can improve that without doing surgery, but that's for another podcast for another time, that we'll talk about kind of skin tightening and some of the non-invasive, non-surgical approaches to that. But there are ways that you can even combine some of these things. Today, I did liposuction on someone's upper abdomen. You can do Renuvion to help them kind of shrink wrap and tighten that. You can do Morpheus RF microneedling to try to add collagen and also cause the dermis to contract in that upper abdomen. And then I did a mini dermalipectomy on her. So she didn't like kind of the fullness of her whole abdomen, but had excess skin between her belly button and her pubic bone. So that's when you can kind of combine these things. So when you talk about the incision, right? So I think we have a pretty similar philosophy on incision placement, which is key to this. What kind of guidelines, what are you using to help guide where you're putting this patient's incision for their tummy tuck?
Yeah, it's, I want to keep it as low as possible for them. It's most discreet. It's typically where a C-section scar is, 7 centimeters above the vaginal, the vagina.
Yeah, top of the vagina.
And from hip to hip. And, I also have patients wear their underwear so I can see where their painting line is, and that helps them see where that scar is going to be as well.
Yeah. And I do the exact same thing. So I have patients wear their most revealing bikini bottoms or panties the morning of surgery, and then they lift up on their lower abdominal tissues, because I tell them your upper pubic area and even your upper anterior thighs are going to get rejuvenated. They're going to get pulled up.
Right.
You want to keep the incision that 7 centimeter distance from the top of the vagina, or you can actually pull up on the vagina, which gets a windblown look, and that's not a crowd pleaser at all. Nobody wants that. And so, but you want to keep it within the confines. I've seen people who maybe don't have a whole lot of skin to remove, and so the surgeon places their incision high, which just makes zero sense to me. So, I mean, I want, when people say, what about my C-section scar? 99 times out of 100 tell them, I'm going to be lower than your C-section scar.
Yeah.
I mean, unless the C-section's like in a crazy place. But I want to take that old scar out, and I want to stay as low as possible. We are using kind of flatter incisions now. You used to see these big kind of U-shaped incisions when women were wearing kind of French-waisted bikinis or underwear, which we just don't quite see as much. So, so I tell people that the length of their incision, when they get in the mirror naked, where they start to see any shadowing of their skin is how long it's going to be. Because I just say, that's how much we've got to remove. Because if we keep your incision relatively flat, like, if you put a pair of jeans on, if we kept it kind of in that same direction, parallel to that line, if we're removing a whole swath of skin, including skin that's like up all the way to your belly button, that's going to be a longer incision than the lower flat one. It just is. And I draw it out for patients. It's hard to kind of...
Yeah, that's a great way to describe it.
It's hard to describe it over kind of a podcast and let people know, but because it's going to be a longer incision on the top, the lengths of those two incisions are different. So you've got to almost work that top down to the bottom and kind of share some of that space, which can leave a temporary pleated look, right? It can look like it's kind of getting pleated, which works itself out. The alternative to that is to have what people come in oftentimes and ask, what's a dog ear? What's a dog ear? When somebody says, hey, my friend got a dog ear after their tummy tuck, what's that mean?
That's when you just have extra skin at the end of the incision that kind of pokes out.
Right.
And so sometimes you need to bring that incision almost, have... on your sides, almost to your up of your butt,
which is an
buttocks, which is an extended tummy tuck.
Yeah. And then what about a circumferential?
Some patients need to have that incision go all the way around.
Right. And they get their buttock and their lateral thigh rejuvenated with that too.
Yeah. That's a great surgery for patients, who want buttock improvement.
Right. And who've lost a lot of weight.
Yep. It lifts that whole area.
It's awesome. You can keep
really
that whole incision underneath their panty line, which is great, or their underwear line, because we do a ton of these on guys too, right? All right. So the key thing, and I think it was the lead in to the hook for this episode of this podcast, is the belly button.
Yep.
I mean, everybody wants to know. I mean, belly button was like that gross little kind of charcoal looking thing on your baby that just kind of fell off, right? So it is a scar by itself. By definition, that's what it is. But what happens to a patient's belly button? Do you make them a new belly button? Do they lose their belly button?
No, you don't lose a belly button. You, the problem with the belly button incision is if it's not done well, then it's a telltale sign of a tummy tuck.
Right.
So I think, we both do it the same way. I think we do a great job at making it. Whenever we make incisions anywhere on the body, a facelift, breast, thighs, arms, anywhere, we want those scars to be hidden in the natural shadows of your body and your anatomy.
Yep.
And you taught me how to, because I've done it several ways, and I saw how yours looked, and I was like, that's how I'm doing mine from now on, and they look the best.
And the belly button's a hood, right? A hood that so many of you got pierced. That's a bad trend. And but sexy in the 1990s. So kudos to all of you who had it. But it's a hood, and then it's a ramp, right? It's not a balloon tie.
Yeah.
It's not a cat's butt.
It's not an oval.
It's not a Target
circle.
sign. It's not anything crazy like that. So so that Omega kind of inset that we do here, I think, really disguises it and really keeps people guessing, because I think when people see tummy tucks, they can easily look at the belly button and be like, oh yeah, look at her belly button. See,
Yep.
she definitely got a tummy tuck. I think the way we do it, it keeps them guessing, which is awesome. But your belly button stays attached to your abdominal wall. We cut around it and just kind of dissect on either side of it. So when you're actually raising the skin and the fat up off of the muscle, the belly button's like a little stalk. It's almost like a little snorkel kind of coming out of there and just sits there. And then as we pull the skin down, we'll pop it back through skin that is actually somewhere on your body between your breastplate and where your belly button is right now. And so that allows us to really kind of keep your belly button in a normal location. The kind of caveat to that, and I don't know if you do a lot of these, what's your experience? Who's a good candidate for like an umbilical float?
Yeah.
Right? Because I do umbilical floats sometimes, and I've got my, great for people who have the muscle separation, but don't have a lot of excess skin. So they come in and they look fit when they're like firing off their muscles. But when you say, okay, have you seen the movie Frozen and Elsa? Let it go.
Yeah.
And when they let their abdomen go, all of a sudden they've got that roundness to them. And you're like, dang, you look so fit and your skin is so great. So what's an umbilical float? How's that different than what we're talking about right now?
Yeah, so that's where you make your incision in the panty line, but you don't make an incision around the belly button. And this can be difficult to get perfect because if the belly button is not in the right spot, that is obvious too. And that can look really weird.
Right.
So, there is a distance on the abdomen between your ASIS where your belly button should be, and that distance varies to a degree. And some people have high belly buttons, some people have low belly buttons. If someone has a low belly button, a umbilical float's probably not the best thing.
It's not going to work, right?
It's just
right. But for a high belly button, and I've got a great picture of two models that are in bikinis, one of which is kind of neat, is a patient of ours, and they are similar heights. Their shoulders are right where they are, but they have very different torsos. And because they have very different torsos and, consummately different leg lengths, their belly buttons are in way different spots. So you're right. If somebody already has a low belly button and you're like, hey, we're going to lower your belly button by another 2 inches, that's going to look crazy. But if somebody has a high belly button or even a normal belly button and you're going to lower it an inch, they may get away with that. And then they don't have any external scar around their belly button. So there's really no way for somebody to look at it and be like, you did it. You'd be like, how'd I do it without a scar? Because it's the umbilical float procedure, which is, so umbilical float is great for patients that don't have a lot of excess skin, especially between their belly button and their breastplate.
Yeah.
And so it allows you to take the belly button along with the skin flap up off of the muscle, fix the little umbilical hernia, fix their diastasis, right? Bring their muscles back together. You pull down. You don't pull down as tight as you did in a standard abdominoplasty, or you probably would pull the belly button into a position that's too low. But it's a super cool procedure, not used a whole lot, but like if you hear that term, umbilical float, know that we think you got pretty good skin.
Yeah, it's a great option for the right patient. It's a great option.
Right. Okay. And so tummy tucks and we talked about liposuction. Let's talk about the recovery, because I think that that's something that people really get worried about. We use Exparel, which is a 72-hour local anesthetic that we inject not only along their incision, but in the wall, the muscle walls, which gives them a lot of alleviation of the discomfort that you can get. I tell people it feels like you just went to a core class and you hadn't been to one in 6 months and you decided to not pace yourself and kind of go crazy. And the next morning, that's what you feel. And that's what you feel for weeks, right? But it's not like a searing, oh my gosh, hot poker sensation. It's just you feel like you've really engaged your core because you have. I send patients home with a walker for that first week.
Me too.
So why do you send them home with that walker?
I don't want them to stand all the way up and put tension on the skin closure.
Right. So, we remove a little more skin than if we just kept the table flat when we were operating on them, but we flex the table. We remove a little bit more, knowing that it's going to stretch out a little bit. And so I tell patients, you talked about blood flow before. Once we've lifted everything up, blood has to get to the bottom of their abdomen, and it's got to bring oxygen with it so that those tissues stay alive and heal and do what they need to. So if I've got, somebody standing up, not only are they going to put tension on their suture repair, which, we use a lot of suture. So you'd really have to pull and maybe do a back bend to cause a problem. But I do it because the blood vessels will be bigger if they're bent over, right?
Yeah,
blood vessels are
true.
tubes. So if you stretch a blood vessel, it's just going to get narrower and deliver less oxygen. So I tell patients, you're going to go home with a walker. You're going to be 90 degrees, right? Which is like if you were sitting with good posture and your mom or your grandma was telling you to sit up well at the table, at the Thanksgiving Day table. That's 90 degrees. That's how much I want you bent at your waist. And it's to take tension off the incision. It's for the patient's comfort, and it's to improve the blood flow with everything, which is great, right? All right. What about when somebody says, I'm an avid exercise enthusiast. I hate my abdomen. I got to get it fixed. I want my muscles back together. But when can I go back to CrossFit?
Yeah, that's probably the biggest barrier, I think, in taking care of patients with abdominoplasties is them being able to recover for anywhere from 4 to 8 to 12 weeks, depending on how much I have to placate their muscles.
Sure.
Sometimes I'll say, I don't want you to do any core type activities, really exercise, CrossFit, that kind of stuff, lifting more than 20 pounds or so for a good 3 months.
Yeah.
But most patients, weeks 6 to 8, I'm okay with them getting back to some exercise activities and lifting.
So I tell patients, I say for the first 2 weeks, I'm not on your Christmas list.
Yeah.
Right?
Exactly.
You're not happy.
Thing.
I don't really want to see you in post-op because you're just going to yell at me or give me dirty looks. And so, but by 2 weeks, you feel so much better. You're standing up. Yes, you're sore. Still can't do anything to disrupt your repair. And the human body is going to heal on the same timeline no matter what, right? At 6 weeks, you're 60% healed. At 8 weeks, you're 80% healed. And then it takes the rest of the year to get that final 20%. So, do I want patients doing inverted Rocky Balboa, sit-ups with twists at the end in the Russian barn? No, I don't. Most husbands will get that reference, but maybe the women won't. But no, I don't. At 6 weeks is when I will let you start quote unquote core exercises.
Right.
And those cores are like a plank. Right? A straight up plank on your knees. That's the first kind of core exercise you're going to do. And you're going to wear your abdominal binder when you're doing all these things. And I tell patients, at 3 months, you won't remember the surgery, right? You'll be like, you know you had it because you can look in the mirror and see what it is. And you're close enough from your surgery that you're like, by God, I'm going to take care of this. And you're not so far away from your surgery, right, that you kind of forget about it and get back to old habits. So I tell people at 6 months from your surgery, that is going to be your prime time. You're going to look fantastic. So I always love that 6 month post-op photo because they're lean, they're mean, they're ready, they're excited, they've been in the gym, they've done all these things, they haven't gone back to their bad habits, which hopefully they don't go back to, but we are all human, right? So, all right, so recovery can take a while. At 2 weeks, I tell patients, get your running shoes on. You can walk in the neighborhood. You can do some light cardio. I don't really need any twisting exercises. So no golf, no pickleball, nothing crazy like that. You're not jumping back to CrossFit at 6 weeks, but you can slowly start kind of increasing your physical activity. You're doing all your daily stuff. At 2 weeks, you're driving a car, you're running errands, you're going back to work, you're being a mom, being a dad, doing those types of things. So, all right. And then when a guy comes to you, because we both see a lot of guys, when a guy comes to you and he's got this kind of big round belly, and he's 30 pounds overweight, and he says, I want you to sew my muscles back together.
Yeah, that's more than likely intra-abdominal fat.
Right.
So
Right.
that's if you try to put those muscles back together, the sutures are going to rip through or it's going to recur.
Yeah, they're going to rip through, and you're going to be in the emergency room
Yeah.
fixing that patient at the hospital. I've seen it happen, not to my patient, but I've seen it happen, and it's scary as all get out. So men tend to hold fat more intra-abdominally, and it can be different, right? We can still get the external tire around our midsection, and even women can come in, and they are like, their fat underneath their skin is nothing. But they still have this round abdomen and they're like, liposuction this. And you're like, what? Like this fat is internal. It's around your organs. So it can't be liposuction. So they've got to lose weight. That's the only way to take care of it.
Yep.
And luckily for them, they can do that through any number of ways. And fewer are having to do surgery, weight loss surgery, to achieve their goals of weight loss. They can do it through medications, which has really revolutionized things, which has been pretty amazing, right? All right, so talked about men. We talked about you don't want a flat abdomen. You want an abdomen that has hills and valleys because that's natural occurring. I do want you to talk about one thing. I may have a different opinion than you, so don't feel bad if I come behind you and say something different. How do you feel about like abdominal etching or any of that kind of stuff for somebody's abdomen? And for patients who don't know what that is, that's when somebody gets like I'm kind of feeding you where I feel about this. Overly aggressive liposuction to certain areas of the abdomen to try to create overly accentuated hills and valleys so that they look like they've got, six packs or things like that. How do you feel about abdominal etching? And if you think it's good now, how do you think it's going to be in 10 years, 20 years when the patient's skin ages?
Yeah, I mean, I think it can look really good initially, but as the patient ages, I really question what's going to happen. I mean, what I do, I don't do that. I talk patients out of that when they bring it up. I don't think if you're making the skin and fat, etching it to the abdominal muscles.
Yeah, it's scarring down, basically.
It's scarring down. That's not a natural thing.
No, because we've seen so many catastrophes from bad liposuction, that's just almost unfixable. And so I tell patients, like, you're wanting me to do this in a controlled environment, and as your skin and tissues age, it's going to look terrible. Now it looks awesome on the OR table. I love all these social media posts and all these they're very skilled surgeons that do the lights all great on the patient, slather them up with baby oil, and then they've got all these rip-roaring looking contours on there. And I just keep thinking to myself, if God wanted that to be scarred down and there not to be any fat in that layer or anything like that, that's how he would have made you.
Yeah.
We see beautiful figures on models or just people walking around who do it through diet and exercise. So long as we get your muscles back to where they're supposed to be, we cut out the excess skin that you have and do that, you should be able to work on the rest.
Yeah.
Right? Through diet and exercise. You can make your tummy tuck result that much better. And so, we kind of put you back to where things were supposed to be. And from that standpoint, sky's the limit for you,
Yep. And the only thing that I do try to define the midline.
Absolutely.
With my liposuction.
I think that's totally safe to do. Yep.
But as far as outlining all six or eight of your ab muscles, that's a horrible idea, I think.
Right.
But
no, awful. This was awesome. I think we've talked, for over half an hour about tummy tucks. Hopefully this has answered a lot of questions for our patients because we get a ton on this. I think, probably, I don't know. We both do a lot of breast surgery, but this has got to be one of the most popular surgeries we do.
For sure.
And I think it's because we have like a pretty consistent approach to it. And I just think people love our belly buttons. I think that's one of the ones that really kind of, right? All right. Yeah. No cap buttholes, no balloon ties for your belly buttons. Needs a hood and a ramp. All right. That way you can get it pierced again, ladies, from the 90s. It'll look great. Spring break. 1995, MTV. All right, if you've got questions or topics you want us to cover on the Doc Dudes, head to ghsurgery.com. Click the Doc Dudes from the homepage for a link to submit questions. Subscribe so you never miss an episode. New episodes drop the last Tuesday of each month. You can find the Doc Dudes on Apple, Spotify, YouTube Music, and everywhere you listen to your favorite podcasts, as well as through our website. Don't forget to follow us on Instagram and Facebook for the latest on new episodes and our practice. This is Dr. Garrett Harper and
Dr. Evan Zug.
And we are signing out on this episode of the Doc Dudes. Thanks, guys.